Welcome to the Deep Dive. Today we're really getting into a core resource for vascular surgeons, Section 12 of Rutherford's, all about peripheral and splanchnic aneurysms. Think of this as, well, basically the instruction manual for handling these conditions.
Yeah.
We want to pull out the really critical stuff you need for diagnosis and management.
Exactly. It's designed to be practical. And kicking things off with peripheral aneurysms, especially in the lower limbs, one of the first things Rutherford stresses is that link to aortic aneurysms.
Right, that connection. But it's different for men and women, isn't it?
Very different. The text mentions up to 14% of men with an AAA might also have a femoral or popliteal aneurysm.
But it's rare in women.
Quite rare, yeah. So the immediate takeaway for you listening is if you find an AAA or a lower limb aneurysm in a male patient, you really should think about getting that extra imaging like a duplex ultrasound.
Makes sense.
Yeah.
Check the other spots. Now, rupture isn't the biggest worry for these lower extremity true aneurysms, is it?
Generally, no, not compared to, say, aortic aneurysms. The much bigger risk, the thing we really watch out for, is limb-threatening ischemia, usually from thrombus breaking off and traveling downstream.
Thromboembolism.
Uh-huh.
Okay, so that raises the question, when do you step in?
And the guidance, the manual, if you will, points strongly towards treating in the asymptomatic phase if possible.
Before they cause trouble. Because once symptoms start, especially embolic ones, the risk of limb loss jumps up significantly.
Precisely. Which is why knowing about these associations and looking for them matters so much.
Okay, let's dive into true femoral artery aneurysms specifically. Rutherford gives a breakdown of where they typically show up.
Yeah, the common femoral artery, the CFA, is the most common spot. We're talking, what, 57 to 81%?
Something like that, yeah.
Yeah.
Then SFA, then PFA, less common.
Right. And about a quarter are bilateral. Plus, almost half of these patients have other aneurysms somewhere else. Aorta, iliac, the other leg.
So you always have to look around. And who gets these typically?
It's mostly older men, often over 70. And the risk factors are the ones you'd expect: smoking, hypertension, mostly degenerative.
Though the text mentions a few rarer links, like Bisset's or Wegeners.
Those are in there. Less
Right.
common, but worth keeping in the back of your mind. Atriomegaly, too.
So how do they usually present if it's not rupture or embolism initially?
Well, a good chunk, maybe 30–40%, are actually asymptomatic, found by chance on a NA scan for something else.
Incidentalomas.
Exactly. Another 30–40% might have local symptoms, pain, tenderness, maybe some nerve compression or leg swelling.
But ischemia is still the most common presentation overall.
Yes, up to 65%, according to the text. That's the main clinical flag. Rupture, again, quite rare, maybe around 4%.
And for diagnosis, the go-to is duplex ultrasound.
Absolutely. It's your first line. Cost-effective, accurate for identifying it.
But not always enough for planning treatment, right?
Right. That's where CTA or MRA come in, essential for planning, especially if you're thinking endovascular.
Yeah.
And crucial for finding those other aneurysms we talked about: aorta, iliac, popliteal.
Got it. So once you've found one, when do you treat? Symptomatic ones are clear-cut.
Yes, symptomatic. You treat. To avoid those ischemic complications or rupture.
But asymptomatic is trickier. What's the size threshold?
Well, there's been some evolution there. Older advice was maybe repair over 2.5 centimeters in good risk patients.
But more recent data suggests maybe waiting a bit longer.
Yeah, some findings suggest observation might be okay up to 3.5 centimeters, especially if there's no thrombus inside. But if there is thrombus,
It might push you towards intervening earlier.
exactly, it lowers the threshold. For smaller ones below that cutoff, watching with regular duplex scans is standard practice.
Okay, so if treatment is needed for a CFA aneurysm, open repair is the standard.
It has been, yes. The usual approach is open repair, exclude the aneurysm, and put in an interposition graft. PTFE or Dacron are preferred.
And you usually leave the sac.
Generally, yes. You open it maybe to control bleeding from branches, but you don't typically resect the whole thing. Less risk to nearby veins and nerves.
And getting proximal control, how's that usually done?
Usually just a clamp on the artery above it, but if it's really big or high up, you might need a balloon catheter inside, or rarely a separate incision higher up, like above the inguinal ligament.
And the type of repair depends on how far it extends down.
Right. If it's just the CFA, a short graft works. But if it goes into the SFA or PFA, you need a more complex reconstruction, maybe jump grafts to keep flow going into both, especially the profunda. You really want to preserve flow there.
Critical for thigh and collateral circulation. What about endovascular for CFA? You mentioned it's not first line.
Correct. It's pretty limited, mostly for emergencies or maybe as part of a hybrid procedure.
Why the limitation?
The big issue is the location right at the groin crease, the inguinal ligament. Lots of movement, lots of stress. High risk of the stent graft kinking, fracturing, or moving.
Makes sense. So maybe useful for quick control in a tough open case,
Right.
but not usually the definitive fix.
That's generally the thinking, yeah.
Okay, let's switch gears to femoral pseudoaneurysms. Totally different beast, right?
Completely different. Not a true dilation of all wall layers. It's basically a contained rupture, often from a puncture.
Usually iatrogenic then, from procedures.
That's the most common cause by far. Catheterizations, maybe after surgery. But you can also see mycotic ones, like from IV drug use or at an anastomosis site.
And how do they present?
Typically a painful, pulsating mass in the groin, often a big bruise or hematoma around it. You can frequently hear a bruit.
And sometimes a continuous bruit if there's an AV fistula.
Exactly. That's a key sign. Patients might also get nerve pain or swelling if it's pressing on things.
What's the natural history here? Do they all need fixing?
Not necessarily. Small ones, maybe less than 2 or 3 centimeters. If they're asymptomatic and the patient isn't anticoagulated, they can sometimes thrombose on their own.
But anticoagulation stops that.
Yeah, makes spontaneous closure much less likely. So if they're larger, symptomatic, growing, or the patient needs to be anticoagulated, intervention is usually needed.
Why? What are the risks?
Skin breakdown over the lump, necrosis, infection, and rupture, which is a real surgical emergency, potentially massive bleeding.
Especially if the puncture was above the inguinal ligament.
Yeah.
Right. Can bleed into the retroperitoneum.
Yes, that's a dangerous situation. Much harder to control externally.
So what are the treatment options beyond open surgery?
Well, there's ultrasound-guided compression, basically squashing it with the ultrasound probe for a while.
Sounds uncomfortable.
It can be. Takes time, requires patient cooperation, can be painful. Success rates vary.
What else?
Ultrasound-guided thrombin injection, UGTI. Injecting thrombin directly into the pseudoaneurysm cavity to make it clot. Generally more effective and quicker than compression.
So when would you still need open surgery?
If it's ruptured, obviously. If UGTI or compression fails or isn't suitable, if there's skin ischemia, infection, nerve compression, or that AV fistula we mentioned.
And the surgery involves...
Usually direct repair of the hole in the artery, maybe with a patch, sometimes ligation if it's a small branch. Need good proximal and distal control, maybe using balloons again if it's tricky.
Okay. Moving down the leg. Superficial femoral artery, SFA, aneurysms, less common.
Much less common than CFA aneurysms. Yeah. Rutherford's notes they're often just extensions from popliteal aneurysms growing upwards.
And we don't know as much about their natural history.
Not as well defined, no. Because they're rarer, generally repair is considered if they get over about 2.5 centimeters or if they're clearly growing on scans.
Surveillance with duplex again?
And if you operate, arteriography beforehand is helpful. Open repair uses vein or prosthetic grafts. Midterm results seem pretty good. Endovascular is still emerging here, less long-term data.
And even rarer are the profunda femoris artery, PFA aneurysms.
Extremely rare. Less than 3% of all femoral ones. Usually just on one side, but bilateral cases exist.
High association with other aneurysms, though.
Very high. Popliteal is the most common one found alongside it. Because they're deep, they can get quite large before being noticed.
And the risks. Rupture, embolism.
Both. Significant risk of rupture and limb ischemia from emboli. So the recommendation is generally to repair them when found because the natural history isn't well known and complications seem frequent.
Open repair preferred.
Usually, yes. Graft replacement or sometimes ligation if it's in a distal branch you can sacrifice. Dissection needs to be careful to avoid the profunda vein. Control might need to be taken high up at the CFA or even external iliac.
Endovascular options here too.
Limited, but possible. Maybe stent grafts for pseudoaneurysms or coil embolization for distal branch aneurysms.
Okay, let's move behind the knee. Popliteal artery aneurysms, PAAs.
Yeah.
The most common peripheral ones.
By far. Over 70% of all peripheral artery aneurysms, almost exclusively in men.
And often bilateral.
Around 50% of the time, yeah. And a strong link to AAA, maybe 30–50% of patients with PAA also have in AAA. Finding one means you need to look elsewhere.
Etiology mostly degenerative.
Yeah.
Like the others.
Primarily degenerative atherosclerosis, but the location, bending the knee constantly might contribute to the stress on the artery wall there.
What's a natural history?
Yeah.
Rupture rare but bad.
Exactly. Rupture itself is uncommon, maybe 2.5%, but if it happens, limb loss is a very real risk. The much more common problem is thromboembolism causing ischemia.
So, like the femoral ones, symptoms are often ischemic.
Yes, that's the most frequent presentation. Anything from claudication to acute limb-threatening ischemia. Sometimes they compress the popliteal vein or nerve, too.
And a key point, a thrombosed PAA might not feel pulsatile.
Right. It can present as just a firm mass behind the knee in someone with acute ischemia. Physical exam alone can be misleading. Don't rely just on feeling a pulse in the aneurysm.
Diagnosis, again, relies heavily on imaging.
Absolutely. Duplex is good for screening and surveillance. CTA or MRA give the detailed anatomy needed for planning. And DSA, digital subtraction angiography, is often still used to get the best look at the runoff vessels below the knee before intervention.
Okay, indications for treatment. Symptomatic ones get treated.
Definitely.
What about asymptomatic? Is there a clear size cutoff?
It's debated. Generally, over 2.0 or 2.5 centimeters is often considered the threshold for repair in patients who are medically fit. Some argue for repairing all PAs once found, regardless of size, given the complication risk.
And thrombus inside makes you lean more towards repair.
It usually does, yes. Lowers the threshold. But it's always an individual decision. You weigh the aneurysm risks against the patient's overall health and surgical risk. Observation of small asymptomatic ones without thrombus is possible in high-risk patients.
So if you decide on elective treatment, what are the main options?
Two main pathways: endovascular repair with a stent graft or open surgical bypass.
Endovascular is less invasive but has limitations.
Correct. Needs the right anatomy, good landing zones above and below the aneurysm, not too much kinking or tortuosity. Also, the patient needs to be able to take dual antiplatelet therapy afterwards, and frequent deep knee bending might be a relative contraindication. It's technically off-label use for stent grafts here, too.
And open surgery.
Yeah.
Still the gold standard.
Traditionally considered so, yes. Usually involves bypassing the aneurysm and ligating it proximally and distally.
Why ligate?
To stop blood flowing back into it from collateral vessels, which could let it keep expanding or embolizing. Sometimes the sac is open to stitch close those collateral branches directly.
Choice of approach. Medial versus posterior.
Medial approach is common, good access to the saphenous vein if you need it for the bypass graft. Posterior approach is better for really large or saccular aneurysms, allows for better decompression, maybe better for an interposition graft rather than just bypass and ligation. You can use prosthetic grafts with the posterior approach too.
And thorough imaging beforehand is key for planning open surgery.
Essential. Need to know the whole picture from aorta down to the foot, plus vein mapping if you plan to use vein.
What about urgent or emergent PAA repairs? High stakes.
Very high stakes. Acute occlusion or bad embolization means high risk of amputation. First step is heparin, then rapid imaging CTA, MRA, or angio.
Treatment depends on nerve function.
That's a critical differentiator. If there's no nerve deficit, you usually get imaging first, then plan the repair. If there is a neurosensory deficit, that's an immediate trip to the OR, ideally a hybrid room.
And in the OR.
Try open thrombectomy if you can see outflow vessels. If not, thrombolysis might be an option to try and clear the distal vessels first, but that takes time and has risks. Hybrid approaches combining techniques are useful here, and watch out for reperfusion injury after you restore flow.
Thrombolysis itself can be a primary treatment sometimes.
Yes, in acute ischemia where the angiogram shows really poor or no runoff, you can use catheter-directed TPA. Needs careful monitoring in an ICU setting, then usually followed by definitive repair, either endo or open, once flow is restored. Rheolytic thrombectomy is another endovascular option. Needs the right skills and setup.
So comparing open versus endo for PAAs overall, what's the bottom line on outcomes?
It's complex and depends a lot on how the patient presented. Some studies show open repair might have better long-term patency, but it means a longer hospital stay and more short-term complications.
Endo is quicker recovery, but maybe higher reintervention.
Potentially higher early thrombosis or reintervention rates, yes. Though meta-analyses haven't always shown big differences in major outcomes like limb loss or death.
So still depends on the patient and the anatomy.
Very much so. Endo often reserved for good anatomy, patients who won't be bending the knee excessively and can take the antiplatelets. It requires a detailed discussion with the patient about the pros and cons of each.
Okay, and just briefly, tibial and pedal artery aneurysms, mostly pseudoaneurysms.
Mostly, yeah. From trauma or access, true ones are rare. Treatment is usually surgical ligation reconstruction or coiling. And don't forget Hypothenar-Hammer syndrome for ulnar artery aneurysm.
Right. Okay, let's move up to the arch vessels. Innominate, common, carotid, subclavian, also usually degenerative.
Degenerative is the most common cause, again, typically in men over 60. But trauma, FMD, infections like syphilis, vasculitis, congenital issues, can play a role.
And again, look for other aneurysms.
Always, especially thoracic aortic and aortoiliac. Also, distal subclavian ones can be linked to thoracic outlet syndrome.
Subclavian aneurysms, specifically true ones, are commonest, but iatrogenic pseudoaneurysms are increasing.
That's what the text suggests, yeah. Mostly degenerative true aneurysms. But with more central lines being placed, we're seeing more access-related pseudoaneurysms. Endo repair is often used for those iatrogenic ones.
And innominate and common carotid true aneurysms are quite rare.
Very rare. Innominate aneurysms have that Kiefer classification based on extent. Open repair is usually via sternotomy, maybe with a neck extension. Complex surgery, sometimes needing bypass.
Common carotid also rare, pseudoaneurysms more likely.
Yes, pseudos after carotid surgery, trauma, dissection, infection. True degenerative ones are uncommon, bilateral, almost unheard of.
How do these arch vessel aneurysms present? Often, incidentally.
Often, yes. Found on imaging for other things. If symptomatic, can be chest, neck, shoulder pain, or symptoms from embolism to the arm, nerve compression, brachial plexus, recurrent laryngeal causing hoarseness, or even breathing problems if they're huge.
Physical signs to look for?
Pulsatile mass above the clavicle for subclavian, maybe a brute, diminished arm pulses, blue finger from emboli, neurologic signs in the arm, hoarseness, Horner syndrome.
Imaging is obviously key here.
Crucial. Test X-ray might show something. Then ultrasound, CT, Messer angiography, CTA, MRA, or conventional is needed to see the full extent, any clots, the vertebral circulation, and if endo repair is even feasible.
Open surgery principles, resection and grafting.
Generally, yes. Resection or endoaneurysmorrhaphy with an interposition graft, prosthetic, or vein. Simple ligation usually isn't done because the risk of stroke or arm ischemia is too high.
And endovascular for arch vessels, still mainly for high-risk patients.
That's right. It avoids the big open surgery but has major limitations. Need good landing zones. Big risk of covering critical branches, carotid, vertebral, internal mammary.
And device issues. Compression or fracture. Stroke risk.
All concerns. Especially subclavian stents getting compressed near the clavicle. Stroke risk during carotid procedures. Need careful planning, often coil embolizing the vertebral artery origin if it's involved. Access is usually femoral or brachial. It's often off-label use of devices. Long-term durability is still a question mark. Hybrid approaches are also an option.
What about that specific situation aneurysm of an aberrant subclavian artery?
Yeah.
Comparel diverticulum.
Yes, the aberrant right subclavian, ARSA, is the most common arch anomaly. Comes off last, goes behind the esophagus. The bulge at its origin is a comparel diverticulum.
Can cause trouble swallowing, dysphagia lusoria.
Exactly, or arm symptoms or aneurysm symptoms. Often found, incidentally, though.
Treatment.
Asymptomatic without comparel, often just observe. Symptomatic or aneurysmal needs intervention. Used to be complex open surgery. Now, hybrid repairs, aortic endograft plus subclavian bypass are often preferred. Total endo options are also being developed.
Okay, moving out to the arm. Axillary artery aneurysms. Rare, often trauma-related.
Yes, rare. Usually trauma, blunt or penetrating. Sometimes in young athletes from repetitive motion or crutch users. Pseudoaneurysms after fractures, dislocations too. Risk of nerve injury from bleeding compression.
Diagnosis with imaging, treatment usually open surgery.
Correct. Arteriography, duplex, CT, Messer open repair with vein graft interposition is preferred. Need to protect that brachial plexus carefully. Good results usually. Endo repair is sometimes reported.
Brachial artery aneurysms, also often trauma, including iatrogenic.
Yes, catheterizations are a common cause of pseudoaneurysms here. Also degenerative, infection, connective tissue disease. True aneurysms less common.
Presentation.
Can compress the median nerve. Local pain. Hand or finger ischemia from clot or emboli. Pulsatile mass. Duplex is key for diagnosis.
Treatment generally recommended.
Yes, high symptom complication rate. Open surgery is preferred patch, vein graft, sometimes simple suture for pseudoaneurysm. Thrombin injection less used here because they're superficial.
And distal upper extremity radial, ulnar digital.
Mostly pseudoaneurysms, again, trauma, access for dialysis. True ones, very rare. Treat with ligation, reconstruction, or coiling.
All right, let's cover the last major area. Visceral artery aneurysms, splenic, hepatic, SMA, celiac, rare but potentially lethal.
That's the headline. Rare overall, but rupture can be catastrophic. Elective repair is much preferred, allows full workup imaging, considering causes like trauma, pancreatitis, infection, pregnancy, atherosclerosis.
Vaccination's important if the spleen is involved.
Yes. Presplenic artery embolization or ligation need vaccines for encapsulated organisms. Endovascular is often the go-to for elective repair in higher-risk surgical patients.
Splenic artery aneurysms, SAAs. Most common visceral, more in women.
Correct, most common. Increased risk in women, especially multiparous, and patients with portal hypertension.
Often found incidentally. Low rupture risk unless pregnant.
Yes, often incidental. Rupture risk 2% usually. But pregnancy is a huge risk factor. High mortality usually ruptures in the third trimester. Portal hypertension also increases risk.
So treat if 2 centimeters, symptomatic or pregnant.
That's the general guidance. Any size in pregnancy. Endovascular coiling, stent graft often preferred over open surgery. Try to save the spleen if possible during open repair.
Hepatic artery aneurysms, HAAs. Second most common. Difference between true and pseudo.
Yes, about 20% of visceral, mostly extrahepatic, more common in men. Pseudoaneurysms tend to be more symptomatic, higher rupture risk, need urgent treatment more often.
Presentation. Can rupture into the biliary tree.
Often incidental. Can cause vague pain. Rupture risk around 25% for larger true ones. Rupture into peritoneum or biliary tract causing hemophilia, jaundice, RUQ, pain, Quincke's triad. High mortality with rupture.
Treatment indications.
Treat all pseudos. Treat symptomatic true ones. Treat asymptomatic true ones if 2 centimeter or growing 0.5 centimeter. Higher risk with PAN or multiple HAAs. Endo is used increasingly. Open options are a ligation or reconstruction.
Superior mesenteric artery aneurysms, SMAAs. Infection a key cause here.
Mycotic is a leading cause, yes. Also atherosclerosis, connective tissue disease, trauma, pseudo.
Presentation often symptomatic even if not ruptured. High rupture risk.
Yes. Often cause pain, intestinal angina, weight loss even before rupture. Rupture rate is high, 38–50%, with high mortality.
So repair basically all of them when found.
That's the general recommendation from guidelines due to the high rupture risk. Repair all pseudos and mycotic ones for sure. Maybe observe tiny true ones in very high-risk patients, but generally, repair is advised. Surgical options exist, but caution with grafts if mycotic. Endo options too.
Finally, celiac artery aneurysms, CAAs, rare.
About 4% of visceral. Atherosclerosis, infection common causes. Male predominance associated with other aneurysms.
Treatment threshold similar, 2 centimeters or symptomatic.
Generally, yes. Treat symptomatic pseudos and true 2 centimeters because rupture mortality is over 50%. Observation for smaller stable ones in high-risk patients might be okay, but they can grow and rupture too. Surgical or endovascular repair options.
So wrapping this up, this deep dive into Rutherford's Section 12 really gives us that essential instruction manual for peripheral and splanchnic aneurysms.
Absolutely. We've touched on the wide range of causes, how vital imaging is for diagnosis and planning, the key differences between true and pseudoaneurysms, and that ongoing evolution between open and endovascular approaches.
And the core message seems to be the need for really individualized patient assessment. You have to weigh the aneurysm details, the patient's health, and the potential for really serious complications.
Right, which leads to a good thought for you, our listeners, to take away. As we learn more about the natural history, and as both open and endo techniques keep improving, how can we continue to refine things? How do we best use these tools to improve outcomes, reduce limb loss, and cut down mortality even further?
An important question indeed. We hope this overview helps you navigate these challenging cases. Definitely revisit the areas most relevant to your own practice. Thanks for joining us.